So getting back to the work of breathing. So the whole idea of CPAP is that it decreases work of breathing. It decreases your respiratory effort to help oxygenation and ventilation. And that's the big goal, is to reduce this work of breathing. So signs of work of breathing, I think you're all very well aware of this. Dyspnea on exertion, when they're walking upstairs or up an incline, I'm getting short of breath. Speech dyspnea, they can only speak in 2-3 word sentences, maybe sometimes 1 word sentences. Tripoding, you know, doing this kind of thing. I had a guy in my office and he sat the entire time talking to me like this. The whole entire time talking to me, you know, and he was, nothing's wrong with him. He was, you know, nothing's wrong with me, I don't know why I'm here, my doc made me come, you know, that kind of thing. But the entire time he gave me a tripod. And I said, I can tell by the way you're sitting and the color of your capillaries and the colors of your lips right now that you need me. But he didn't want to, have I seen him back yet? I can't remember if I've seen him back yet. But anyway, so you can tell just by certain little things that you can pick up on physical exam. You don't even have to do a full physical exam. You can just sort of see, you know, if they're not oxygenating and ventilating well. With apnea, you know, do they have to sit upright to breathe? How many pillows are they using at nighttime? Are they sleeping in a reclining chair? Accessory muscle use, you guys have seen that, you know, that they're working hard. You can see them using their muscles. Lung sounds, labored breathing, or no breath sounds. So if they're wheezing when you walk into the room, or you don't hear any air movement, sort of one or the other, bad signs. Rales, crackles, rhonchi, wheezing. So the increased work of breathing causes respiratory fatigue, respiratory distress, and then eventually respiratory failure. And then CPAP really tries hard to decrease the fatigue that's happening and prevent them from needing to be intubated. So the types of pre-hospital CPAP, there are basically 5 that I came across in the literature. And I must say, I don't know them super well. I tried to read up on them and try to figure out why would you use one versus the other. The first one I'll talk about is OxyPeep, and I guess you guys are using that. You're using OxyPeep, and East Kingston's got OxyPeep. And OxyPeep technically is not CPAP. So the others are CPAP, but OxyPeep, they call it CPAP, but the difference is that it doesn't apply a pressure during inhalation and exhalation. It only applies positive and expiratory pressure. So when the person's inhaling, they're not getting an extra pressure, but when they exhale, they get a pressure. There's a difference that versus seeing a constant pressure whether you're inhaling or exhaling. That's CPAP. You see, you know, 10 centimeters of water, like you're driving in a car and you put your head out the window and it's blowing on you constantly whether you're inhaling or exhaling. That's CPAP. OxyPeep actually is you're breathing normally when you inhale, but then you get this sort of, I don't know, a different way of thinking about it. When you blow up a balloon, when you first blow up the balloon, it's hard to get over that pressure, and then the balloon stays open. So keep that little air in there, and then just go. So that's the positive and expiratory pressure. So anyway, OxyPeep is a single patient system. It can go, it's easily transported, I believe, from the truck into the ED. You can give high flow O2 without an assorted, you know, needing valves or this or that. So it's kind of an easy system. You can adjust your oxygen from 32% to 95% with a diluter. It has an adjustable PEEP valve, so I think you can go up to 20. You can go, you know, 5 to 20. It's inexpensive, lightweight. You can apparently do vent weaning on it, although I don't think I've ever done any vent weaning on an OxyPeep. And you need an O2 tank and a flow meter. Then there are regulator-based portable CPAP devices. And again, CPAP, continuous positive airway pressure through inhalation and exhalation. It generates flow from O2. It's a continuous pressure from O2 flow. You can vary the oxygen concentrations. There's a typo there, sorry. It's often, it's compatible with end-tidal monitoring of CO2 levels and inline medications, so you can give meds. The disadvantage is that these things are bigger. They can cost $1,000 to $1,500, and they may not be compatible with the hospital. And I think these are two types of the regulator-based systems, the Port O2 vent and the Care vent. And are you guys familiar with those or no? Have you used them before? Yeah. The regulator-based portable CPAPs, just to give you an idea, at 10 centimeters of water of a CPAP pressure and 100% oxygen, a D-size cylinder will last 20 to 30 minutes. If you go 65% FiO2, then it lasts 35 minutes. And depending on your transport time, you know, one may, if you have a 45-minute transport time, that's not going to be a doable system for you. There's also a Buznak CPAP. The advantage is that this is a picture of it here. It's an accelerated oxygen through a series of channels, and it creates a turbulence, and it acts as a virtual valve generating the pressure, generating the positive pressure. It's disposable, it's lightweight, it's cheap. You can transfer it to the wall of the ED O2 pretty well. The limitations of this one is that it can only go up to 10 centimeters of water. It can't go higher than that. And the flow rates can be 25 liters a minute. And that's what that one looks like. So for CPAP at around 5, a D-side cylinder will last 23 minutes. But at a pressure of 10, it's only going to last 14 minutes. Then there's these whisper flow generators. I've not used these before. Anybody familiar with these? Yep. Variable flow rates from 0 to 140 liters per minute. It delivers oxygen from 28 to 100%. You can use it with kids and adults. It's compatible with a variety of different CPAP masks and valves. It's relatively inexpensive, but I think these are just ones on the truck, and I don't know if how easily it goes into the ED in terms of transferring the patient into the ED. So, indications for CPAP: early respiratory failure, acute pulmonary edema, heart failure. It's used in COPD and some asthmatics, and there's also been indications for pneumonia. Now, there's a variety of other things that are talked about in the literature, and I'll touch on them very briefly at the end in terms of using CPAP. But the two big ones that are used are acute pulmonary edema and COPD. They're the two big things in the pre-hospital arena in terms of why you would want to use CPAP. And asthma too, if you've gone a couple rounds of meds and they haven't really improved, CPAP can help there as well. So contraindications to using CPAP. It can cause hypoventilation in some cases. You're not supposed to use it in altered or diminished level of consciousness, or if that starts happening, don't use it. Airway compromise if they've been vomiting in burn patients, foreign body choking, you're not supposed to be using CPAP. Single lung disease if they have a pneumothorax, if they've had a lung out, if they have cancer, or if they've had trauma. So those are the cases that you would not use CPAP. So in acute pulmonary edema, the etiology could be med non-compliance, which is probably the most common one we see, MI, arrhythmia, pregnancy. Signs, this is sort of classic textbook stuff: foamy, blood-tinged sputum, this really light pink sputum. In my many years of taking care of respiratory failure patients, the blood-tinged sputum thing happens probably 10–15% of the time. It's not very common. There's more going on that sort of really indicates that they're in CHF. They have accessory muscle use. They may be agitated. They may look cyanotic. They might have that purple hue to their lips or their fingernails. Those are the areas that I look at pretty quickly when I assess somebody because there's your high capillary flow or in your fingernails and your lips. They may have bilateral edema in the feet, ankles, lower extremities, rales or crackles on physical exam, usually at the bases of the lungs. They may have cardiac asthma, wheezing, elevated JVD, and abnormal vitals, obviously. Symptoms: respiratory distress, dyspnea, orthopnea, PND, and chest pain. So the treatment of acute pulmonary edema, I don't want to go into all your protocols, but CPAP in combination with high flow oxygen, nitro, Lasix, and opiates. And then, how does it work? The increased lung pressure holds the alveoli open. It allows for increased hydrostatic pressures, getting the fluid out of the alveoli into the interstitium and back into the vascular space, especially if you're using Lasix to mobilize that fluid out of there. It increases oxygen transfer, increases the surface area, so it helps. Decreases preload, decreases afterload. It actually improves cardiac output. Switching gears to asthma and COPD, in general, either obstructive or reactive airway problem. The etiology of the bronchoconstriction can be from any environmental trigger: cold, smoke, humid days, pollens, animals, you name it. It could be med non-compliance or infection. Signs are similar: accessory muscle use, tiring, wheezing, tripoding, agitation, cyanosis, abnormal vital signs. The treatment for your COPD or your asthma patients: CPAP in combination with high flow, bronchodilators, magnesium, epi, and solumedrol. In general, it increases oxygenation. CPAP also increases the effectiveness of medications up to 80%, so it allows the medications to get in and work better. In general, refractory to normal interventions, you use CPAP when they haven't been responding to the normal things that you would normally do. Give them the inhalers, assess them, see if they're improving. If they're still very dyspneic, tripoding, then try CPAP. So you should try at least 2 rounds of bronchodilators before CPAP. It overcomes the work of breathing by superimposing on auto PEEP, and I thought that this is actually an interesting concept. So when I actually thought about it on my bike ride into work today. So I was going up the hill right there by the farm before South, is it South Road? No, it's on South Road, that hill. And as I was riding up, I noticed that I was doing some pursed lip breathing. And the reason why I was doing some pursed lip breathing was because I am trying to auto PEEP. I am trying to keep my alveoli open to better exchange my carbon dioxide and my oxygen because my legs are burning. But auto PEEP is a real thing. Hopefully I don't have bad lungs, but I don't think I have bad lungs, and I'm doing it on purpose. I'm doing it because I'm trying to make my oxygenation and my ventilation better so that I can get more oxygen to the muscles that need it so that I can get up this hill. So what happens is when somebody is in a full-blown asthma or COPD attack, they're really working hard. They're using your accessory muscles to keep the alveoli open. And so what happens is when you give them a little CPAP, you're now doing that for them. So those muscles that are being used to try to stent those airways open are now relaxed, and they're now able to be used for inhalation rather than during exhalation to keep those airways open. So all of a sudden, the work of breathing gets a whole heck of a lot easier for that person. So it seems a little counterintuitive that you're like, oh no, they're auto PEEPing, they're air trapping. Why am I pushing more CPAP in them? Well, they're air trapping because they need to keep those airways open for the gas exchange. And if you put a little positive pressure in there, give them like 5 centimeters of water to keep that open for them, now those muscles that they were using can be